Hi everyone, Dr. Simon Fryler, consultant in clinical neurophysiology here. This video is really to support a lecture at the Institute of Neurology, which I will have given by the time you're seeing this. There's a series of cases within this little lecture relating to how we integrate neurophysiology numbers into clinical practice. There's already a part 1 video which you can link to on the iCard above, where you can see how the different nerve tests are actually captured and what they actually represent on the screens that we see. It's not just about physical dry numbers that a computer churns out. These are actual waveforms that we are marking up, and there are different techniques which are employed in order to do all of this. So hopefully you'll find it useful and beneficial if you've attended the lecture, just to go through things. Of course, if you haven't been there, then that's fine too. And I'm really glad that we now have more cases available here online for people to go through if you're interested in neurophysiology and trying to understand how all these numbers come together to help make a diagnosis. So without further ado, let's get into it. Numbers in neurophysiology are inherently complex, and they are quite frightening to those who are not neurophysiologists and aren't working with this data day in and day out. There are lots of reasons for variability in the data. Some of these can include factors such as height, so taller people tend to have smaller sensory nerve action potentials, and girth, for example, is also quite an important factor. Someone tends to have smaller responses, and the reason for that's pretty simple, in fact, because there's more padding between the surface electrodes and the nerve underneath. So there are lots of potential factors that one has to bear in mind, and if a patient has, for example, edema, that can also be a factor to take into consideration too. And so when it comes to actual data interpretation, one does have to rely on your neurophysiologist who is performing the studies. But having said that, there are some relatively easy numbers to remember. I've devised a system rule of 5, which we'll go through in a moment. But there are ways of trying to remember things in a useful way. Another couple of things just to point out as well are that the conduction velocities of the nerve segments tend to increase in speed as one moves more proximally. A couple of reasons for that: the nerves become warmer, and they're also larger in diameter, so the conduction speeds go up. And then there's a 50% rule, which means that if one side is 50% less of the other, then that is likely to be an abnormality. So let's now look through the rule of 5. If we take an average build 40-year-old, then the sensory responses, and these are measured in microvolts, so millionths of a volt, will be for the ulnar nerve 5 microvolts, median 10 microvolts, and superficial radial 15 microvolts as minimums. Now, as one increases in age, that snaps, those sensory nerve action potentials may decrease in size, may halve, so there might just only be 2.5 for the ulnar in an 80-year-old, there might be 5 for the median digit 2, and 7.5 for the radial. If one is younger, then one can increase the amplitude, what we would expect for those, so it'd be 10 microvolts, 20 microvolts, and 30 microvolts respectively. In terms of the velocities now, so the conduction velocities would be roughly about 50 meters per second at the 40-year-old age bracket, and they will decrease a little bit as one gets older, maybe about 45 or so. Reasons for that can include either degeneration of the nerves themselves a little bit with the process of aging, and also the fact that older people have more impaired thermoregulation, so the limbs tend to be a little bit cooler too. As one is, if one's younger, I should say, then the conduction velocities may be 55 meters per second as a minimum. One will tend to see much higher conduction velocities than that in the younger cohort, but these are sort of minimums to expect. Let's have a look at the lower limb now. So we only have to really remember 2 nerves for the lower limb, the sural and superficial peroneal, and for the average 40-year-old, there'll be 10 and 5 microvolts respectively, with a conduction velocity of about 40 meters per second. If one has an older patient, then one can effectively halve those again to 5 and 2.5 microvolts respectively, or if one has a younger patient, there might be 20 and 10 microvolts respectively, and the conduction velocities as a minimum will be that little bit faster, 45, and as again I mentioned, for the older patients they tend to be a little bit slower, so about 35 over there. So really quite a simple system for the average build. person at a variety of ages. So if you just remember the rule of 5s for the average 40-year-old, then you can either double it or halve it depending on the age, respectively. Now the motor studies are a little bit more complex because there are a few more numbers to try and remember, but for the average build 40-year-old, the distal motor latency, so those are the most distal points of stimulation. So one stimulating over there, the signals traveling across the nerve, going across the neuromuscular junction, and then depolarizing the muscle membrane. So distal latencies for the ulna at the ADM about 3.5 milliseconds, 4.5 for the APB, 5.5 for the EDB, and 6.5 for the tibial AH, respectively. Upper limb conduction velocities, again about 50 meters per second, 40 meters per second for the lower limb. And then for the amplitudes, one would expect for the ulna roughly about 10 millivolts, so it's 1,000th of a volt, 5 millivolts for the median APB. So that's about half of that. For the tibial AH, we would expect at least 5 millivolts, and for the peroneal EDB, about 2.5 millivolts. The F responses, which we went through in the previous video, would be less than 33 milliseconds for the upper limb and less than 55 milliseconds in the lower limbs. Of course, as one ages, those values will also increase somewhat too. Let's dive now into case 1. So a 46-year-old lady who has got numbness in the whole of the right hand. Let's go through this sequentially. So if we have a look at the right median finger 2, we've got an amplitude of 5 microvolts over there. So that's less than our 10 that we would expect. The conduction velocity here is 37 meters per second. So that's also less than the 50 meters per second that we would be expecting. So that's reduced, and that's reduced over there. Let's compare that to the control left side. So the left side was 16, so that's very normal, that's above 10. The conduction velocity was 57 meters per second, so again, that's very normal too. And so in terms of the median sensory fiber function, it's really reduced in its amplitude and it's reduced in its conduction velocity. If we compare that also with the ulnar data, we can see that the amplitudes here for the ulnar snaps are roughly about 10 microvolts over there, which are normal. It's above the 5 microvolts that we would expect as a minimum. And the conduction velocities are about 50 meters per second. So again, those are appropriate conduction velocities. So what we have so far is sensory conduction slowing with some loss of amplitude as well. Let's have a look at the motor data now. So for the median APB, so the distal motor latency on the right is 5.3 milliseconds. That's greater than the 4.5 milliseconds that is normative. So we've now got delay of motor fibers. The left side was only 3.2. We can see the conduction velocity has decreased a little bit. It's 41 meters per second versus the 51 on the other side. So that's a little bit down. Let's just put a little arrow on there for that being prolonged. The motor action potential over here, the CMAP, is 5.4 millivolts, so that's okay, although I would say that that's a little bit on the low side, but just borderline on that one, and 7.6, which is absolutely normal on the left hand side. So we can see here we've got motor fiber impairment as well. The F latency, just going down a little bit over here, is 33 milliseconds. That's a little bit prolonged compared to the 29. Obviously it's not dramatically increased, but it's a little bit prolonged over there too. The ulnar data, so we're going to look through this line by line as well. So 2.3 milliseconds versus 2.2, that's fine. Conduction velocities in the forearm over here, 55 meters per second, that's absolutely normal. And as we go to the conduction velocity around the elbow, that's increased in its conduction velocity, so that's appropriate too, so that's great. Those are normal. We can double check that with the left side, and very symmetrical. Then in terms of the motor amplitudes, so these are all very normal motor amplitudes on both sides, and the F latencies are about the same. But again, just comparing the F latency between the APB and that of the ADM, that is absolutely normal over there. It's 30, and this one we were saying was a little bit on the borderline, like so. So we've got sensory and motor fiber impairment of the median nerve, and so we have a peripheral neuropathy over here. It's something that's happening quite distally. We've got this prolonged distal motor latency, and we have a moderate right carpal tunnel syndrome. And the reason I highlight this case as the first starting case is, for number one, this is absolutely going to be the most common scenario that you're going to see as a neurologist, someone with whole hand symptoms. And it's important to note that common things are common, and 40% of people who've got carpal tunnel syndrome have effectively extramedian symptoms, and so carpal tunnel is always very high on the list of differentials. Let's have a look at case 2 now. So 46-year-old lady with numbness in the ring finger and into the forearm. Now, the first thing before we even dive into the actual numbers over here is, if we're thinking about the differential, is it an ulnar? Is it a lower cervical radiculopathy? But if it's an ulnar, then I would be extending into the forearm, so one has to bear this in mind when one's doing the test. So let's have a look at the median data. We've got absolutely normal snaps for the median nerve and normal conduction velocities, so those are all okay. We can ignore that. There's no carpal tunnel there. The right ulnar snap is reduced over there. That's just 2 versus the normal 11 on the left hand side. The conduction velocities are appropriate. So we've got a peripheral neuropathy over here. The ulnar snap is reduced. So we need to be thinking about an ulnar process. So how do we square that with the clinical side of it, where there's numbness going up the forearm? Always bear that in mind as you're doing the test and as you're interpreting the data. Let's have a look at the motor study. So for the distal motor latencies on the right hand side, that's normal. We can check that one off. 53 meters per second in the forearm, that's normal as well. Normal amplitudes over there. F latency is also normal. If you weren't sure, you can compare to the other side, and it's all very similar. Ulnar nerve now. So distal motor latency is 2.6. That's okay. Not a problem with that. Conduction velocity in the forearm, 55 meters per second. That's also okay. However, let's have a look at the conduction velocity around the elbow. That's actually reduced. Remember, conduction velocities increase as one stimulates more proximally, and this is now just 37 meters per second. So that's a problem. So there's a conduction velocity slowing there as the signal is going around the elbow, and we have the reduction in the sensory amplitude as well. Let's have a look at the motor amplitudes here. There's a fair bit of reduction in the motor amplitudes over here, and in fact we can even see when we stimulate above the elbow that there's a degree of conduction block that's significantly less than the more proximal below elbow stimulation sites, more than 50%. So there's some conduction block going on over there, and the F latency is increased. We can also note as well that the motor amplitudes are a fair bit less than on the contralateral side, which was a very normal 11. So there is sensory and motor fiber impairment, and we know that the motor fiber impairment is going around the elbow too. But remembering, of course, that the symptoms are not fully in keeping with an ulnar neuropathy, and so what we've decided to do at this point is let's do some EMG. I've taken you through a little bit about the EMG on the preparatory video for this, but suffice it to say that these are large units over here. You can see some of the polyphasia going on as well. And if we have a look at the data table over here, we're going to see that the deltoid and the biceps, those are very normal over there. That's fine. Triceps, which I just showed you, we've showed some large polyphasic units coming in. There was a moderately reduced interference pattern, and those have gone up to about 5 millivolts. EDC as well, similarly, very similar picture over there. And if we look at the first dorsal interosseous, there's some fibrillations, and again some further reduction in interference patterns and so on. It's all very neurogenic, and so in fact what we have here is a combination of an ulnar neuropathy at the elbow and also a cervical radiculopathy at C7-8 level, and it's not uncommon for us to see two entities at the same time. Now, just as a separate point, just to talk through this with you and take the opportunity with ulnar neuropathies at the elbow, anybody who's got any shoulder pathology is at risk of developing an ulnar neuropathy at the elbow. They might have a frozen shoulder, they might have a plexopathy, C5 radiculopathy, any of those causes that might lead to somebody leaning their elbow onto something to support it, or perhaps somebody who's perhaps wheelchair bound, all at risk of developing ulnar neuropathy at the elbow, and just to highlight for that for your delectation. Let's have a look at case 3 now. A 42-year-old gentleman with right lower leg numbness. So we're going to work through the sensory nerve action potentials first, because we need to differentiate whether we're dealing with a peripheral neuropathy or something more proximal. And so let's go through this line by line. Right sural, amplitude of 12, that's fine. 14 for the left side, so that's all very, very normal. Superficial perineal one, so we can see there's a bit of an asymmetry going on over here. Technically speaking, I mean, this is, acceptable, but that's very normal. So there might be some impairment of these sensory fibers over here, and you might very justifiably think that there is a peripheral neuropathy process, but hold that thought. Let's have a look through the motor conduction values now. So distal motor latency 5.1, 4.9, that's fine. Conduction velocities in the lower leg 49 meters per second, that's fine. As we go round past the fibular neck, it increases in velocity to 56 meters per second, so that's fine as well. But when we have a look at the motor amplitudes, one can see that there is quite a discrepancy here. Those are reduced relative to the left hand side, and also we can see that the F latency here is also prolonged compared to that of the left hand side. So are we dealing with something going on with the perineal nerve? We've so far got impairment of the sensory nerve action potential for the perineal, and we've also got motor fibre impairment too, with some prolongation of the F wave. Let's have a look at the tibial AH responses. Distal latency is okay, that's fine. Motor amplitudes, well, that's reduced, and certainly compared to the other side. And the F latency is also increased. So now we've got two F latencies which are increased from different muscle fibers, and so we're really needing to be thinking about a radicular process here, probably the L5S1. So we're going to go into our EMG, and we're going to see that there are some fibrillations over here, and we can see degenerating units over here, polyphasic large, going up to about 6 millivolts. So we'll very much a neurogenic and active picture over here. Now, I've already mentioned and alluded to the fact that the superficial perineal sensory nerve action potential response was reduced, and this is not uncommon. This is probably the only real pitfall with this differentiation of the pre- and post-ganglionic processes for radicular diseases is with this superficial perineal one, because basically its dorsal root ganglion lives in the lateral recess, and therefore any of the processes of degeneration that will extend into that sort of lateral recess will affect the dorsal root ganglion, and therefore one will have some reduction of the superficial perineal response in that scenario. So that's just something just to be aware of, to look out for. It's something that we commonly see. It's rare that we see it completely obliterated. Usually there will be a little bit of something left, but it's just something to bear in mind. That's sort of the caveat for the localization differentiation between pre and post ganglionic processes using the sensory action potentials. Let's have a look at case 4 now. We've got a 41-year-old type 1 diabetic patient who's had diabetes for about 15 years and has numb feet. So let's start at the bottom. So superficial perineals, both sides are absent, so there's a neuropathy going over here. Sural responses over here are reduced as well. Let's have a look in the upper limb. Ulnar responses are reduced, and the medians are also down too. So we can see overall there's a bit of a gradient here of sensory nerve action potential reduction. Conduction velocities are borderline reduced, but basically okay. Let's have a look now through the motor conduction data and just work through line by line again. So for the medians, distal motor latencies, well, they're less than 4.5, a little bit on the slightly prolonged edge of things, but they're less than 4.5, so we'll just count that off as okay. Conduction velocities, again, just a little bit slower than I would like them to be, but kind of okay. Motor action potentials, again, kind of okay. F latencies, a little bit borderline raised, but kind of okay. And this is quite typical in diabetes. Things are sort of borderline-ish for either reduction in amplitudes and borderline for conduction velocities as well. Let's go through the ulnar data. 3.2, again, bit on the borderline. Conduction velocities, well, in the forearm 33, 36, they're definitely on the slower side. As the conduction velocities round up the elbow, they do speed up, so that's okay. So let's just mark off those forearm reductions over there on both sides. Motor amplitudes, again, everything's borderline, a little bit smaller than it should be. F latencies, again, just borderline, a bit prolonged. Comperineal data, so 5.6, 5.9, that's okay. 37, 40 in the lower leg, again a little bit slower than we'd be expecting. Round of the fibular neck does increase in velocity, but again a little bit slower. Motor amplitudes are reduced bilaterally, and the F latencies are increased too. Tibialis on the AH. Posterior tibial nerve to the AH, again we have reduction in the motor amplitudes and some prolongation of the F latencies too. So everything here, both for the sensories and for the motors, are either borderline or reduced. It's more the sensories that are affected than the motors, and so effectively we've got a length dependent sensory more than motor, predominantly axonal neuropathy with what we would consider to be mildly demyelinating features, and this is all very typical in long-standing diabetes. The only thing I'm just going to say to you as an extra point worth considering is the patient was only complaining of numbness in the feet. When one does have a neuropathy in the feet, I always think it's a great idea, just check the upper limb too, because the patient may have some mild neuropathy going on, which is as yet asymptomatic for the patient, but the process is still going on. And in general, by the time you have neuropathies going up to the knees, there tends to be some form of neuropathy in the hand after that point. Case number 5, a 47-year-old gentleman with right arm weakness. In this scenario, let's have a look again line by line. So are we dealing with peripheral neuropathy? We need to have a look at the sensory nerve potentials first, and those are all okay. That's not a problem, and normal conduction velocities. Let's have a look at the feet over here, and again, this is just a warning sign really that there's been some extension of the study. If the patient's only been referred with one limb and you see more data going on elsewhere, you get a feeling that there's more going on over here, and all the sensory nerve responses are absolutely fine. So far the sensory responses are fine for upper and lower limbs bilaterally. We've now done a fair bit of motor studies here as well. So for the APB, what we can see here, distal latency 4.3, 4.2, borderline but okay. Conduction velocities are okay-ish in the forearm. The motor action potential levels are reduced bilaterally, but more so on the right hand side, and left latencies a little bit prolonged, but not anything to write home about. So far we've got reduction in motor amplitudes both sides, and the patient was only complaining of weakness in the right side. Let's have a look at the ulnar data here. So again, distal latencies are okay, conduction velocities in the forearm are okay, and above the elbow are okay. Again, motor amplitudes are reduced over here, and F latency again a little bit borderline. On the left hand side again we can also see a little bit of reduction here too, but obviously not as much as on the right side. Let's have a look at the lower limb, and I'm just going to zoom in onto the motor amplitudes here. They're all okay bilaterally, and for the AH they're okay. F latencies are okay as well. Conduction velocities are okay. Nothing tremendous over here. I mean, this is a little bit borderline, but they're okay. So far we've got, if we just go back a little bit, we've got normal sensories, upper and lower limbs. We've got reduced motor amplitudes in the upper limbs, asymmetric more on the right hand side, legs unaffected. So we're now moving on to EMG. We've got someone with right arm weakness. Seem to have a motor neuropathy. When we think about motor neuropathies or motor fiber involvements, you've got to really think about motor neuronopathies, the anterior horn cell diseases. And so because they've got right arm weakness, let's start at the top. I'm just going to show you a couple of EMG screen grabs really. We can see on this screen over here we've got some positive sharp waves, we've got some fibrillations over here, so there is spontaneous activity, and in fact when we get the patient to activate the muscle, we can see lots of polyphasic units all over the place. So there's regeneration going on over here, there's reduction in the interference pattern as well. Let's have a look at the lower limb. So patient has no symptoms over there. Again, we're seeing some positive sharp waves, and what we can see here also are these enlarged polyphasic units which are present too. So we've got subclinical denervation going on in the lower limbs, and actually this is a case of motor neuron disease. And if you haven't come across the paper, there is a cardinal paper which everyone should read, which is the Mimics and Chameleons paper by Professors Turner and Talbot. Highly recommend anyone who's got any interest in motor neuron disease to read it. It really does highlight the value of neurophysiology actually in looking at all the differentials for MND. A barn door MND certainly can be diagnosed clinically. I think there is a lot to say for having neurophysiology in the early stages, and it's very rare that you are presented, particularly in DGH, with an absolutely clear-cut case of motor neuron disease. Often there are differentials which have to be worked through, and that's really where neurophysiologists earn their money, in addition to which it's looking for subclinical denervation in regions which have not yet been affected. So the things that we're looking for is active denervation with reinnervation. We're looking for fasciculations. You want as many regions as possible, ideally 3, it might be 2. There are scenarios where you might even raise a suspicion at 1, but that's quite unusual. But 2, you start raising the suspicion. My personal feeling on this is that it's better to get patients plugged into a specialist clinic to have a look at all of these at the 2 stage, rather than waiting endlessly for the 3 stage, where there's less ability to intervene by that point. Obviously we're trying to improve the quality of life for patients with motor neuron disease, trying to find treatments for them. The earlier we can identify patients, in my opinion, the better we will be in order to fight this really difficult condition. So you want to find as many regions of denervation as possible. You really do have to look, and you're looking really for signs of subclinical denervation. It's also really important to look for myotomal patterns with it as well, rather than single nerve patterns. If you're seeing single nerve patterns, single nerves being involved, and you're thinking about motor neuropathy such as MMN, multifocal motor neuropathy with or without conduction block. And sometimes you might need to see patients on a serial basis, and you're looking for signs of progression. Some motor neuron diseases are very slowly progressive, but on the whole, if you have a gap of a couple of months between the studies, then one can often see progression in such patients. Let's have a look at case 6 now. So someone with proximal weakness. So in this scenario, let's have a look at the median and the ulnar ones. So hopefully a little bit more au fait with the numbers over here. The amplitudes here are very nice for the median and for the ulnar. Again, we're dealing with someone with proximal weakness, and we've got these distal responses over here, but they're normal conduction velocities bilaterally. Sural superficial perineal responses, again we can tick those off, they're all very nice, and normal conduction velocities bilaterally too. So we still as yet haven't got a clue as to why there is proximal weakness. Let's have a look at the conduction values. Distal latencies, fine bilaterally, conduction velocities are fine, motor amplitudes, to be honest with you, they're a little bit on the low side over there, but the F latencies are unimpaired. So far we've got a reduction in the motor amplitudes. Let's have a look at the ulnar nerve. Again, 3.2 bilateral distal latencies, those are fine, conduction velocities are fine, the forearm and around the elbow bilaterally. For the CMAPs, again, motor amplitudes a little bit on the small side, but normal F latencies. So are we dealing with a motor neuropathy again? Let's find out. Comperineal, those are fine, so conduction velocities and lower limbs fine. Amplitudes in this scenario, these are okay, we can tick those ones off. Normal F latencies and posterior tibial, those are fine as well. So far we've got some upper limb reduction in motor amplitudes, and would that be a motor neuropathy. So in this scenario, we're doing some EMG, and what we can see over here on this screen grab, we've got some really small spontaneous activities going on over here, really tiny. The gain here is 100 microvolts per division, so these are just a fraction of a division. So even if it was 10%, so we're talking about 10 microvolts there, really small. And then as soon as the patient activates the muscles here, this activity here is about 50 microvolts. So an absolutely full interference pattern here, small polyphasic units. This is myopathy, and in fact over here I just showed you the transition between that sort of at rest, that's activation, so really rapid activation of the muscle fibers, and as I showed you in the preparatory video, that is the hallmark of a myopathy. So this was a myositis. I think EMG is a really useful tool. You get a very fast answer. It's actually minimally invasive when you compare that to a biopsy. It's incredibly useful to identify potential sites for a biopsy as well. You might notice that when we do sample on the right hand side rather than on the left if possible, just in case someone might need to have a biopsy done. We don't want to ruin the specimens by introducing various scarring artifacts in that. There's always a question as to at what point EMG is useful for studying myopathies. CK levels, personally I haven't seen an positive EMG when it's sort of less than maybe 1,000 in my own experience. I've tried to see any data in the literature about this. I haven't found any hard and fast data. If you have found something, then please do enlighten me. I'd be quite grateful. But relatively slightly raised CKs, we don't tend to get a positive response out of those. And similarly with steroid myopathies, we also don't tend to get a result out of those ones, primarily because of the type of fibers affected by steroid myopathies are not the type of fibers that we pick up with EMG. Case number 7. So we have a 49-year-old gentleman with progressive weakness in the legs. So let's start down at the bottom. We've got absent sural and superficial perineal, so those are all down. So we're dealing with peripheral neuropathy. Let's have a look at the upper limb. So we've got median and ulnar responses. Well, they're obviously down, they're gone. The radial responses are down as well. So the only thing we've got left so far in this scenario are reduced radial snaps. So definitely a peripheral neuropathy. Let's have a look at the conduction velocities and so on. So over here we are not getting anything out of the EDB or the AH. When I reach that scenario in my clinical practice, I always go a little bit more proximally, see what else you can get. So this is on the tibialis anterior, so we're doing a little bit more proximally by the knee, and again absent. So we've got absent sensory responses, absent motor responses in the lower limbs. In the upper limbs, what we have over here, let's just work through this sequentially, just take it very carefully. Distal latency here of 11.8, so that's a fair bit increased. Conduction velocities also reduced. This is, I would call it asymmetric, I think that would be fair to say. Motor action potentials are reduced bilaterally, but a little bit more so on the right hand side. F latencies are increased bilaterally. So this looks something demyelinating over here. And ulnar, let's have a look at that one. So here we've got a distal latency of 6.2, 5.8, so those have also increased. Conduction velocities are reduced as well. Motor amplitudes are a fair bit reduced too bilaterally, and F latencies are also prolonged. And in this scenario we're just going to show you some EMG. And was there absolutely nothing going on in the tibialis anterior? Actually, when we do a EMG on that, we can see a fair bit of fibrillation over there and small distant units at high rates, quite a hallmark of a severe neuropathic process going on, and there's a fair bit of demyelination going on here as well. So this is a peripheral neuropathy. We've got this demyelinative pattern, particularly in the upper limbs. It looks external in the lower limbs. When you have this, you need to start thinking about various gammopathies, which might include poems. Are there any hints or pointers towards that? I've personally diagnosed a case where the patient, I noticed, didn't have hair on their legs. So that's something you might actually pick up on. It's not always what you do see. Sometimes it's what you don't see. So it's something to think about. So that's a very typical type of pattern. Case number 8 over here, someone with ataxia. So very simple. We've got no responses in the upper or lower limbs. For the motor conductions, so we have wow, these are really increased. These distal latencies massively increased bilaterally. So if we were talking about a distal latency of being about 4.5 milliseconds, I mean, this is about 4 times, okay, on both sides, right? 4 times what you would expect it to be. The conduction velocity here, which, we'd expect it to be about 50 meters per second or so, is what, 2736. So I mean, it's really about half. Okay, so there's a bit of a discrepancy going on here between the very distal stimulation and more proximally, where the conduction is only slowed by half rather than by a quarter. Motor action potentials are reduced bilaterally. F latencies are increased bilaterally. Ulnar nerve over here, so normally we should be talking about 3.5 again, so we're talking about a 4 times increase over there. The conduction velocities in the forearms it's about a 25% reduction of what we'd be expecting, 25 to a third. They do increase around the elbow. Motor action potentials, again, reduced bilaterally. F responses are increased. So again, there's this general discrepancy between the distal stimulations and going more proximally, where the degree of impairment is dissimilar. Let's have a look distally. So we've got absent motor responses from the EDB and the AH. Having looked at the tibialis anterior muscle over here, this is quite a prolonged distal latency over there. Normally it's about 3.5 to 4 milliseconds, depending on where you put things. We've got a fairly reduced motor amplitude there, and again, the conduction velocity is only relatively mildly decreased. So there's quite a marked difference overall between the distal stimulations and more proximally. And again, we've got good going denervation on EMG and the tibialis anterior muscle. So in this situation, we've got a marked sensory neuropathy, we've got marked distal demyelination over here, and you've got to start thinking about another gammopathy, anti-MAG. Now, one of the things that is quite a hallmark of this is this marked distal demyelination. There is a value called the terminal latency index, which you might see reported in certain labs, and that's basically the relationship between the distal motor latency versus the conduction that's going on in the intermediate segment, and that's given by this formula over here. And if that ratio is less than 0.26, then one has to think about such gammopathies like an anti-MAG. Last case to talk about, and well done for sticking with me here. We've got a 32-year-old lady who's got rapidly progressive weakness, and by now you're all super experts at looking through these SNAP values. So medians, they're all okay, and that's bilaterally, and ulnars are okay, sural okay, superficial perineals all okay, normal conduction velocities, just ticking these off. Motor conduction velocities, again, those are normal amplitudes, normal F latencies. The ADM studies, normal latencies, normal conduction velocities, normal amplitudes, normal F latencies. And for the perineal and the AH, I'll just tell you straight out, let's just tick those off and avoid wasting your time. But we have got a lady with rapidly progressive weakness, and we have not identified a peripheral neuropathy, nor have we identified a motor neuropathy, any evidence or hint of a myopathy really with this. So what is going on? So at this point, you need to start thinking about doing repetitive nerve stimulation. Over here, you've got a train of 10 stimuli going at 3 hertz. You can see a very characteristic reduction over here, and then subsequent increase a little bit over there as it tails back off. Sorry about that. And this is absolutely characteristic for a neuromuscular junction transmission disorder such as myasthenia. I think it's a nice opportunity now just to talk a little bit about what makes a good referral. Remember, nerve conduction studies do large fibres. Always have a clear hypothesis. Avoid the word exclude. We very much are a specialty that proves things, so we beat to a Bayesian drum. So if you're looking for carpal tunnel, please say, I think the patient has carpal tunnel. If in doubt, always feel free to ask. If you don't believe in the conclusion, please ask as well. Sometimes things do change. We are a clinical specialty, much the same as you're a clinical specialty, and the nerve conductions and EMG usually precede the clinical picture, and it's can be a really useful early warning tool, but also sometimes they can also be similarly confused as various processes at a molecular level take place. If you want more information, please do go to my YouTube channel for more of that. Please do support the channel by liking, sharing and subscribing. Really appreciate that. I hope you enjoyed the lecture, and see you in the next one. Many thanks.